Now we're going to talk about critical care medicine, and this is going to be fun.
Dr. Martin,
Yes.
so for our finals in both Pulm and cardiovascular, are we going to have the social justice and LGBT thing? Because we also have those this week.
Don't worry, if you have them, I'll give you the answers. Nobody should flunk any exam because of those social justice stuff. It's supposed to help you be aware of issues, not cause problems.
I appreciate that.
I didn't hear what you said.
I was trying to counsel it.
Okay. Okay. So let's talk about critical care medicine. This is really, I like this because in the ICU, you can make changes and see people come back to life from the dead, and it's exciting. So what is it? Critical care medicine is diagnosing and treatment of reversible, life-threatening cardiopulmonary conditions. So what is critical care medicine? It's about life-threatening cardiac and pulmonary conditions. How do we manage them? Yeah, that's what we do with critical care medicine. All right, and we already talked about shock, right? So you all know about shock. You know that hypotension is not shock. In order for you to call it shock or cardiovascular collapse, there must be biochemical and laboratory evidence or clinical evidence of tissue hypoperfusion. The patient must be altered. Lactic acid must be elevated. So very important. Clinical and laboratory evidence of tissue perfusion. I see this a lot in your exams. My goodness, they ask it in so many different ways, making sure that we understand that low blood pressure does not mean shock. You should panic when there is evidence of circulatory collapse. And we talked about all the types of shock. Remember that? Yeah. Good. So let me ask you something. If somebody has, you know, I see a lot of questions in your boards where they try to, instead of giving you the shock or asking you to describe the shock, they will give you a condition. Like one I saw that I thought was really cool was that a patient with tension pneumothorax. That's it. Tension pneumothorax, and they paint a picture of hypotension and hypoperfusion. And then I say, what type of shock is this? Hypovolemic shock, obstructive shock, cardiogenic shock. I'm like, come on, man. That is, of course, obstructive shock, right? Right. So that is the kind of thing that they will give you. Like paint a picture of carbonac and all this other stuff. Or they'll tell you, oh, this person has been having profuse diarrhea for 2 weeks. And now they're coming to you, blood pressure is 90 over palpable, BUN creatinine is elevated. You suspect the patient is in shock. What kind of shock is this? Hypovolemic shock, obstructive shock, those type of things. So even though I give you a list of causes under here, it is extremely important that you take your time to go through each of these like we did the last time to understand the pathophysiology of it. Why is it obstructive shock? Especially for the this obstructive shock, pulmonary embolism, cardiac tamponade, and tension pneumothorax are the only 3 causes of obstructive shock. There is no other cause of it. Okay? So you can remember that, very, very important. They ask it a lot. I don't know why. Again, you've seen this before. This is how you evaluate shock. I'm not going to repeat it. You remember this from the last cardiology lecture, right? The one you will see the most in practice is the distributive shock, okay? And again, evidence of hypoperfusion, motile clammy skin, don't forget that. Motile clammy skin, altered mental status, low blood pressure and tachycardia. You can see low blood pressure and tachycardia in somebody that is just hypovolemic. They are not in shock until you see these other things, especially altered level of consciousness and motor clammy skin. Okay? That motor clammy skin is so key, very important. Sweaty and mottled, all right? And you remember I told you that one of the first things you want to do is to show that there is shock, that there is tissue hypoperfusion. So you look for the missed venous O2. If missed venous O2 is normal, that means your patient has a distributive shock. So it's not that there is the blood vessels are just now wide open. There is more space inside the blood vessel than there is blood. Okay, so more of the blood is staying on the venous side than is coming to the arterial side. That's why it's called distributive. And you find that in septic shock. Okay? And what septic shock is the only shock where you have clinical evidence of tissue hypoperfusion with normal mixed venous O2. Because that is the only shock that does that. Okay? And then everything else, you remember, I use CVP. CVP is low, you know that is hypovolemic shock. Patient is losing volume. Okay? And then you remember we talked about how you tread, and this was one place where I didn't go over the waves, and somebody gave me an answer, and I left class and I was thinking about it, and the answer was wrong. So let me go over this with you. The A wave is due to atrial contraction. Okay? The C wave is due to tricuspid valve motion. Okay? The V wave is due to tricuspid valve opening. Okay? And the rapid Y descent is really due to atrial filling, and the X descent is in atrial in ventricular system. Remember what happens with ventricular system is that the chamber shrinks and the AV ring gets sucked down. So that creates that S descent. Very important that you don't get those confused, right? And here is another way of looking at shock. Cold, clammy, warm extremity. Remember the one I told you that only septic shock will give you normal mixed venous O2 in the presence of shock. And because in septic shock, it's a distributive shock, right? More blood is staying on the venous side than on the arterial side. So the patients are not cold and clammy. They're actually warm. Okay? That's why it is called warm shock. Okay, it's the only one that is called that. Okay? When cardiac output is low, you ask yourself, is the patient getting enough blood or not enough blood? It is divided into cardiogenic versus obstructive, depending on what your findings over here. This is supposed to be a critical medicine lecture, and because I've talked about this, I hope I'm not going too fast for you. You understand what this is all about, right? Or you want me to go through it again? As a way of revision for you, maybe?
Yeah.
Okay. So shock is a patient cold and clammy. That means it's a low output shock. If the patient is warm, that's a high output. Right there you have a diagnosis, is distributive shock, right? The patient is warm, right? Septic shock, see, stops right there. Antibiotics, right? Now, if output is low, the next question you want to ask yourself is output low because the heart is not doing its job or because there is nothing to pump, right? So you look at JVP. If JVP is high, that means, yes, the heart has something to pump. The problem is with the heart, that's why JVP is high. If JVP is low, the heart is empty. JVP low, that means it's hypovolemic shock, right? Now, if JVP is high, jugular venous pressure is high, that means the blood is in the heart. Then you have to decide, is it obstructive or is it cardiogenic? Okay, then you now do all the tests to figure out what you're dealing with. And the quick and dirty way is do an echocardiogram. You will see heart failure with reduced ejection fraction in cardiogenic shock. And if it's not cardiogenic shock, the only other shock it will be is obstructive shock. Right? If there is tamponade, you see it there. If there is no tamponade, then tension pneumothorax, the history will suggest it. Right? You see how you use all the information to make up your mind about the type of shock that a patient is dealing with. Right? Again, these are hemodynamic parameters. I want you to pay attention to these numbers, not for any specific reason, because in the exam I'll give you what normal is. Okay, but for the test, some questions that we'll do down the road. Okay? You remember how you paired this? Right? You did this before, right? So we don't need to go over this again. You already know. And you did it so well the last time. But just for me to be sure. What is case number 4? Exactly, neurogenic shock. Excellent. It's low, everything is low, low, low. Cardiac output is low, you expect to have a high peripheral vascular resistance. And the fact that you don't have a high peripheral vascular resistance in the systemic vascular resistance in the presence of low cardiac output means something is wrong with the nerves. They are not, the relay is not going properly. Remember that? Okay. You want me to go over this? Okay, that's it. All right, so case number 1. CVP is high, right? Something is wrong with the pump. Wedge is high. That is really bad because that means the tank is full on both sides. Cardiac output is low. Oh, there's a problem with the heart. Your SBR, the nerves are intact, and the lung is clear. So what is this? Cardiogenic shock, right? Right? Low CVP, well, the tank is empty on both sides. Cardiac output is low, well, of course. And vascular resistance is high. That is appropriate because of low cardiac output. Lungs is clean, so this is what? Exactly, hypovolemic shock, right?
You said number 1 is what?
Cardiogenic, yeah. This one, tank is empty. It's hypovolemic shock, right? Case number 3, CVP is high, so tank is full on the right side, but tank is empty on the left side. Right? Remember, wedge is always a reflection of the left atrial pressure. Right? So a low wedge means, well, the left atrium is empty, but the right atrium is filled. So something is wrong where? In the lung, exactly. And the way you confirm that, look at the pulmonary vascular resistance is high. Right? So you should be comfortable with analyzing these numbers, right? Excellent. How do you treat shock? Well, what is the problem with shock? Tissue perfusion. So what do you have to do to treat them? Increase tissue perfusion. Increase tissue perfusion. And usually it's IV fluids. You have to choose the fluid properly, right? If your patient is losing blood, you give them whole blood. If the blood loss is chronic, you give packed red cell. If you don't have blood, or your patient is third spacing, you give colloid, like albumin or dextran. We're using less and less of it every day now. Remember what I told you about, okay, if your patient is losing salt, you give crystalloids, right? You will talk more about this in surgery, emergency medicine with Katie. Are you guys doing emergency medicine now? No, okay, yes, with Katie, like in the summer, right? So whatever your patient is losing is what you give. Now let me ask you something. If I give 1 liter of albumin to a patient that is in shock, how many mils of that 1 liter will stay in the intravascular space? Just
What was the question one more time?
If I give a patient in shock 1 liter of albumin solution, how much of it can I expect will stay in the intravascular space?
So that normal.
No, albumin. If I give 1 liter of albumin into the patient, how much of it should I expect will make it to the intravascular space?
300.
No, all of it. All of it. Remember, whatever you're given will distribute like it does in the body. Albumin is found only in plasma, right? So when you give albumin, it stays in plasma, right? If I give 1 liter of normal saline, because normal saline is sodium water, and sodium is restricted to the extracellular space. So all of my 1 liter of normal saline will stay in the extracellular space. And remember, the extracellular space is divided into 2, extravascular and intravascular. So 2/3 of that 1 liter will make it into the extravascular space, and only 1/3 will make it into the intravascular space. If on the other hand, I give the patient 1 liter of B5W, 5% dextrose. 5% dextrose has 50 gram glucose in a liter. 50 gram glucose is like a candy bar. So the body will munch up the glucose and you'll be left with just water. And that water will distribute just like body water. 2/3 of the water in your body is inside your cell. It's in the intracellular compartment. 1/3 is in the extracellular compartment. Of the water in the extracellular compartment, 2/3 is in the interstitial space, and 1/3 is in the intravascular space. Of the 1/3 in the intravascular space, 2/3 is on the venous side, 1/3 is on the arterial side. Just remember that rule of thirds for body fluids. Okay? So if I give you 1 liter of B5W, I will only get 100 cc into your blood vessel. That's why we don't use D5 for fluid replacement in somebody in shock. I want to get all the fluid into the intravascular space so I can improve perfusion. I will not use D5, I will use normal saline. Okay? And if I'm in some serious situation, I will use albumin. I want something that will fill the intravascular space as soon as possible. You got that? Okay.
Question, you said 2/3 in the venous side, 1/3 in the arterial?
Yeah. So all the fluid in your intravascular space, 2/3 is always on the venous side and 1/3 is on the arterial side. Okay? So this treatment of shock is always, you want to give fluid, you want to replace fluid. You replace fluid until you're sure that the tanks are filled. How do you know that? The wedge. That is why you always put a wedge. You put a wedge, you put your pulmonary artery occlusion, you catheterize the patient, measure the wedge, and you keep giving them IV fluids in whatever form until the wedge is normal. When the wedge is normal, you now stand back and ask yourself, is my patient still in shock? If your patient is still in shock with a normal wedge, then you now give vasopressors. Right? You don't give vasopressors before you fill the tank, because you'll be forcing the blood vessel to constrict on an empty space. You're going to okay. So the first thing you do is IV fluids until the wedge is normal. That means the tank is full. Then you now give vasopressor. And vasopressors are norepinephrine, dopamine. Norepinephrine is what we use the most, right? They have relative advantages and disadvantages. Don't forget that dopamine is a very weird vasopressor. At a low dose, it dilates the renal arteries. So sometimes what you find in patients in ICU, they give them norepinephrine and dopamine is always low dose. Because you see, norepinephrine will vasoconstrict all the blood vessels, including the renal arterioles. And it will compromise urine formation, right? So in order to protect the kidneys from the vasoconstricting effect of norepinephrine, you give dopamine low dose at the same time, so that you can increase blood pressure and maintain renal perfusion at the same time. You got that logic? Good. Very important that you get that. Then, if after you've given the patient vasopressor, your patient's blood pressure is still not coming up, then you give inotropic agents. You now give medications that stimulates the heart. So it's extremely important that you understand the medications that are used in the treatment of shock, why they are used, when they should be used. So if you come into the emergency room and somebody's wedge pressure is 6, and the ER doctor is planning to give them dobutamine, you'll be like, what's going on? Why are you giving dobutamine with a wedge of 6? You should be giving IV fluids to get the wedge to be normal, right? So that when the wedge is normal, and you don't even go to inotropic agent, you go first to vasopressors, right? Tell me, when does it make sense to go to inotropic agent without getting wedge up or giving vasoconstrictors? When does it make sense? Thank you. In cardiogenic shock, you may want to give inotropic agents before you give vasopressor. You know why? Because when you do vasopressor, you are going to be increasing the pressure the heart has to overcome to pump blood out. And if the shock is a cardiogenic shock, your patient will be worse if you give vasopressor before you give inotropic agent. So, this is why I like critical care medicine. Because if you do it correctly, you see people come back from the dead. And sometimes you see people die. I mean, I've been on consult in ICU services, and patient is on his way out because no attending has come to see what the residents were doing. And they were just cranking vasopressors on the patient in CCU. Why are you doing that? It's cardiogenic shock. By giving vasopressor, you're killing that heart. It's already weak. By giving vasopressor, you're making it work harder than it should. As a matter of fact, that is the reason in the CCU we give inotropic agents with nitroglycerin. And nitroglycerin is actually, to some extent, a vasodilator, right? So we stimulate the heart and we we dilate the blood vessels by reducing the resistance that heart has to overcome to do what we're stimulating it to do. You got it? Mm-hmm. Yeah, it's like a juggling 3 balls at the same time. But it's fun because the result is immediate. And I'm sure you've seen this before. Again, this is what I've been talking about. The very first thing you want to do is you want to check CVP. If the CVP is low, you want to give IV fluids. Why are you giving IV fluids? You want to get the CVP to be at least 8 to 12. Once you're sure that venous return is adequate and CVP is normal, you check the blood pressure. With a normal CVP, a low blood pressure is then your indication for vasopressor. When you give vasopressors and you get the blood pressure up, you check your venous O2 again. If your mixed venous O2 is low, in spite of normal blood pressure, then you're dealing with something else. That means circulation is fine, but what is circulating is junk. There isn't enough blood enough hemoglobin to carry oxygen. Even though blood is flowing, it's junk blood. It can't carry enough oxygen because it doesn't have enough hemoglobin. Then in that case, you have to give packed red cell, right? It's only when you've done all that, or you think that your patient has When you've corrected the CBP, maintain blood pressure, make sure your patient has enough hematocrit, that you have actually treated your patient. Again, remember the 2/3 and 1/3 distribution rule. This is a limited version of it. It also extends into the intravascular space. Don't forget that. Body water, 2/3 intracellular, 1/3 extracellular. In the extracellular space, 2/3 extravascular, 1/3 intravascular. That's how it is. So normal saline, distributed essentially extracellular. So 2/3 interstitial space, 1/3 intravascular space, right? And albumin, if I give albumin, if I give a liter of albumin, how much of it do I expect on the arterial side of the circulation? 300. Because the 1 liter will stay essentially within the intravascular space, right? And since at any given time, 2/3 of it will be on the venous side, so I'll get like 700 on the venous side, and only 300 will be on the arterial side. You got that? Right? Answer me.
Yeah.
Okay. So this table, I gave it to you before, is a table that we used depending on the kind of fluid we think the patient is losing. When patients are vomiting, you give them isotonic saline. That's the one we use the most. But if somebody has been in the I'll say somebody has diabetes. Polyuria will give you normal saline. Anyway, normal saline is what we use the most. Okay? We don't use hypertonic saline anymore. We used to, but hypertonic saline, like 3%, all those things, we don't use it anymore. These are all the fluid. This is what they contain. These are their indications. Be careful. These are the warnings over here. This table is for your information, just for you to know what you can know. I will never test you on this. Nobody will test you on this because there is very little difference between those fluids. Okay? The only thing you need to know that I know somebody will test is you never use D5W to treat hypertension. It's no, you never do that. Okay? If you don't have normal saline in somebody with cardiovascular collapse, but you have half normal saline, would you refuse it because it's not normal saline? No, provided it's not D5 or water, you can use it. It does not, so whether you use half normal saline, hypertonic saline, very little difference, okay? So we don't test that a lot. Okay, so that is shock, half of the critical care medicine. Remember, we said critical care medicine is the management of life-threatening cardiopulmonary conditions. And the only cardiac condition that qualifies is shock. Now, pulmonary conditions, the only pulmonary condition that qualify is the acute respiratory distress syndrome. That is a scary term. Whenever you hear anybody in acute respiratory distress syndrome, or ARDS, they have a 30 to 50% probability of being dead in 24 hours. That is the sickest you can get as far as the lungs are concerned. It is also known as acute lung injury, or ALI. Acute respiratory distress syndrome is a pulmonary response to acute alveolar capillary membrane injury. Okay, so this is what normal alveolar looks like. When there is ARDS, see what it is. And you wish this is what it is, because this makes it look like alveolar filling disorder, right? But it's not, it's worse than that. It's not just fluid. In ARDS, the alveolar cells, they are shedding inside the alveolar cavity. And even when the walls are empty, they are getting stuck together because of the lack of surfactant. So it's not just like an alveolar filling disorder, no, it's way more than that. Okay? What are the causes of it? There are pulmonary and there are extrapulmonary causes. The commonest cause of ARDS is pulmonary, 35% of the time. So usually it's somebody that develops pneumonia, especially aspiration pneumonia, right? And then the ARDS will complicate the pneumonia. There are other causes, extrapulmonary, like sepsis, shock, trauma, burn, hepatitis, DIC, transfusion. It does not matter what the cause is. Bottom line, ARDS, once it's settled, we treat all of it one way. It does not matter what causes it. What you need to be concerned about with ARDS is who is at risk for it and how is it diagnosed. That is the two important questions. So it's extremely important for you to realize that pneumonia is the commonest cause of it, okay? And then sepsis, and then you have a bunch of other causes for it, right? Including drug overdose. So look at what I was discussing with you earlier, as in pathophysiology of ARDS. It goes in 3 phases. There is the exudative phase. In the exudative phase, which is within the first 3 to 7 days, you have interstitial edema, you have alveolar edema, you have neutrophil influx, then you have hyaline membrane with all these cells now sloughing and the alveolar space getting denuded. See, this is your surfactant. It is your surfactant that acts as a soapy layer that prevents the alveolar wall from sticking together. You know, like when the slides, when you do them in soapy water and you put them together, it's easy to separate them than when you put them in ordinary water, right? So the surfactant behaves like soap, makes it easy for the alveolar wall to expand and come together nice and neat. In ARDS, you're losing surfactant layer, right? And you're forming this inflammatory layer called hyaline membrane. And you have all this debris. So you see, it's not just fluid. So it's not an alveolar fluid. There are cells in there. Everything is really bad. And then by 7 to 21 days, you're getting proliferation of the alveolar type 2 cells and fibroblasts. Fibroblasts are coming in to clean up. And in the process, they are converting the alveoli into a fibrous tissue. Most of the time, it will recover in 21 days. If the patient is lucky, the alveoli will do a good job and they will recover with the normal lung architecture. But some unlucky patients will end up with loss of normal architecture. This is bottom line for the pathophysiology of it. All you need to know is that there is injury, the alveoli fills up not just with fluid, but also with cells, and the hyaline membrane develops. Hyaline membrane is an abnormal membrane. It is formed to replace the surfactant layer. Okay? How does it present? Respiratory, just what it says, acute respiratory distress syndrome. So what is respiratory distress? Tachypnea and dyspnea. Exactly. How do you diagnose dyspnea? Nasal flaring, tracheal tone, supraclavicular resection, intercostal resection, active use of abdominal and respiratory muscles for respiration, and pulse ox is low. So when pulse ox is low, that is an indication for you to get blood gas. Okay? On room air, PO2 on blood gas should be about 90 millimeters of mercury plus or minus 10%. And what is the first thing you will do? You give oxygen, right? Generally speaking, in critical care medicine, if somebody is on 60% FiO2, you expect the PO2 to be at least 60. Okay? If somebody is on FiO2 of 100%, you expect the PO2 to be at least 100. Don't forget that. It's a rule of thumb. Okay? So when you look at the blood gas, what really are you looking at? I want you to know that the reason we do blood gas, there are only two reasons we do blood gas. One is to assess the oxygenation, and the second reason is to assess acid-base disturbance. In endocrine, I will talk about acid-base disturbance in endocrinology, but today for critical care medicine, we're only going to talk about oxygenation. Yeah, blood gas analysis in the lab, when you do surgery lab, you will learn some things about it. Because what you want to do is, you're going to clean, and then you're going to stick your needle in the artery, usually in the radial artery. You can use brachial, but most of the time with the radial artery, and the blood will push, because it's an arterial sample, it will push the plunger up, and the syringe will fill with blood by itself. The common error is that the tube has heparin in it, right? So you're supposed to squat the entire heparin out, and then stick the needle in the artery, and let the plunger be raised by itself. Sometimes some people leave heparin in it, or they even leave air in it. So when you leave air, you create a blood-air barrier. Well, air has a lot more oxygen than blood, so you will make your blood oxygen level falsely elevated, right? So there are some sampling technique, and also once you take the blood, you're supposed to run it to the gas lab immediately. If you leave it sitting, red cells are going to mop up the oxygen and release carbon dioxide. So the numbers are not going to reflect the patient's numbers, but they're going to reflect the red cell metabolism, because you let it sitting for too long. And in order to minimize that, we often stick it in a bag of ice. So you draw the blood and you stick it in a bag of ice. The reason we stick it in a bag of ice is to slow down the metabolism. If for any reason the lab will not run it on time, because it's not like the lab is waiting for only your patient sample. There are samples from NIC, CC, MIC, SIC. It's as a line, right? So you don't know when you get the just sample. So you stick it in ice to slow down the metabolism, to minimize the interference of red cell metabolism on your blood gas result. Are you with me? Excellent. All right. So, the alveolar air, the venous sample, usually PO2 is about 40, PCO2 46. This is what it looks like on the arterial sample. Why is this important? Well, the truth of the matter is that you want arterial sample, but many times people will stick the needle in the vein, right? And because of the proximity of the vein to the artery, the pressure will actually make the plunger come up, right? But if you're smart, if you look at it, you'll see that this blood is darker than it should be, right? So you need to know when this is a venous sample. Because if you drop and your PO2 comes back at 40 and PCO2 at 46, that is more likely to be a venous sample than an arterial sample. Because actually, your patient is not going to be alive with a PO2 of 40, right? If you get an arterial sample, this is what you get like. This is what it looks like. PO2 is about 100 and PCO2 is about 40. Now, there is something I need you to understand. I really hope I can do a good job to help you understand it. In patients with cardiogenic shock, arterial blood gas is not a reliable index of ventilation. Does that make sense? Why the ABG will not be reliable in somebody with cardiogenic shock? Because remember, we are looking for an index of ventilation. So, I want an index that will show me is oxygen getting to the lungs and is blood flowing past the lung in sufficient quantity to maintain oxygenation. If there is congestive heart failure, there is stasis, blood is not flowing. And if blood is not flowing at sufficient fast rate, my blood gas analysis is not a reflection of ventilation, but a reflection of the stasis. You got it? Because blood is not flowing sufficiently fast enough, the tissues are getting forced to extract more oxygen than they ordinarily would. You understand what I'm saying? Because the blood is not flowing fast enough, the blood is going to be desaturated below 70%, which is under normal circumstances. When hemoglobin arrives at the tissue with 100% saturation, by the time it leaves, it's about 70% saturation it leaves with, because blood flows really fast. But when blood flow is slow, as in cardiogenic shock, the cells will pull oxygen, and the blood, by the time it gets to the venous side, will be like 60-50% desaturated. So blood gas is a reflection not of ventilation, but more of the stasis caused by the cardiogenic shock. So that is the reason that when patients are in cardiogenic shock, we rely more on the mixed venous oxygen saturation drawn from the pulmonary artery, okay, than we use ABG from the peripheral. Understand that, right? I hate this class. You're tired, sedative from your lunch. I need the feedback, please. All right? Somebody could ask, why don't we use the central venous oxygen? Well, why? Why would we use central venous oxygen? Central venous oxygen is only the venous oxygen concentration from the up part of the body, from the head, not from the whole body. Your head is only about 10% of your body, right? So we cannot use CVP. So when there is cardiogenic shock and you really want to know what the ventilation status of the patient is, do not use peripheral blood gas analysis. Use mixed venous O2, drawn directly from the wedge, pulmonary artery, okay? This is what ARDS looks like. You see that? This is a patient that came in on admission. Day one, they were treating pneumonia. Next thing you knew, day two, it looks like he's getting fluid overloaded. Day three, see what has happened. It looks like pulmonary edema, but because of the acuity, you have to call it ARDS. Okay? You see this white out is the typical radiological manifestation of ARDS. How do you diagnose it? When there was this Berlin conference in 2012 where they came up with methods for diagnosing it based on timing, chest imaging, the origin of edema, and the oxygenation. So they say within 1 week of clinical insult, you have to have bilateral opacities that result in respiratory failure, and you are not able to get a patient to respond to oxygen therapy. Then I was the PF ratio. You remember PF ratio? Right? Okay, I hope you do. Everything works together. All right, so this Berlin conference said this is how you diagnose ARDS. It's everything I've told you, right? There is an initial insult. It could be aspiration pneumonia. It could be a pneumonia. It could be a regular pneumonia. It could be sepsis. That insult. And usually within a week, you just infiltrate. And not only do you see the chest infiltrate, the patient is going into respiratory failure right under your nose. And what is unique about that respiratory failure is that it does not respond as well to oxygen therapy. So PF ratio tends to be very low. In severe cases, it could be less than 100. Okay? So that's how you diagnose ARDS. How do you treat it? Well, how do you treat it? You start out with oxygen, right? Nasal cannula, dry oxygen. You can use cannula. This is not new. We talked about this before, right? Use cannula if you're planning to use anything less than 5 liters per minute. If you're going to use more than 5 liters per minute, you're better off with face mask. And you know that with face mask, you can get as high as what? 50%, right? When your patient requires more than 50% FiO2, you have to use a non-rebreathing mask. You remember that, right? Excellent. If you have your patient, you know the valve device of non-rebreathing mask, we went over this before, right? Good. It is only through a non-rebreathing mask that you can get FiO2 of 100%. Okay? Remember I told you that ARDS, under those circumstances, we expect PO2 to be at least 100 milliliters of mercury if the patient is on 100% oxygen, or at least 60 milliliters of mercury if the patient is on 60% of oxygen, right? When you have a patient on non-rebreathing mask, and you're able to get them close to 100% FiO2, and they are not responding, that is the indication for mechanical ventilation. That is when you have to intubate your patient and put them on mechanical ventilation. When a patient is in respiratory distress and you don't do anything about it, they go into respiratory fatigue. How does respiratory fatigue present? Chest-Stokes and Biot breathing. And I'm giving you what it looks like. Chest-Stokes is this erratic respiratory breathing. It's like a bloody tachy syndrome. Patient takes this shallow breath, deep breath, alternating, very zigzaggy, and then they stop, and then they continue. Whereas in Biot, they continue at the same rate and depth, but then there are moments when they actually stop breathing because they're getting tired. These two are characterized by apneic episodes. They are signs of respiratory fatigue. That patient will stop breathing and will die if you don't do something. That is why don't wait for respiratory fatigue. Don't wait for respiratory fatigue. Call the RT, order the mechanical ventilation when your patient is in respiratory distress and you are not able to get it to turn around with oxygen therapy. Okay? Respiratory failure, again, PO2 less than 60 on 60%, PO2 less than 100 on 100%, it does not matter. You don't have to get to 100% to diagnose ARDS. If your patient PO2 is less than 60 on 60%, that is ARDS. Okay? And then hypocapnia with PCO2 above 45 with pH changes. Why is it important to get pH changes when you have PCO2 elevation? Because the PCO2 changes that you worry about are the ones that are associated with pH changes. If the PCO2 elevation is not associated with changes in the pH, that means it's a slow onset, slow progressive problem that allows the body to accommodate to it. Because under normal circumstances, if you retain carbon dioxide, you form carbonic acid in the blood, and carbonic acid will dissociate into hydrogen ion and bicarbonate ion. So under normal circumstances, with acute CO2 retention, your pH goes down because your hydrogen ion concentration goes up. That is an acute problem. That is a battle that the body is losing. So I want you to always remember, don't make decision based on anybody's PCO2 without knowing what the associated pH changes is. Because if it's a chronic CO2 retention, the pH will not, because the body is dealing with it successfully. If the pH begins to fall, then you're having respiratory acidosis. That means the body is losing the battle. That is when you actually have to do something about it. Okay? Excellent. So now you're going to put the patient on mechanical ventilation. What is mechanical ventilation? You guys want a break? Yeah? Okay, let's take a break. Yeah. Because this is it's going to be very important. That's why I gave you this break. You know? And
2 hours.
if I can't get you to stay up and stay awake, you know what I'm going to have us do? We're all going to stand here. And I'll make it like this is an ICU and we're around it. It's difficult for you not to. I'll make you think on your feet. Literally. So please stay up because this is important and there is a lot of I don't know why there is a lot of questions in this exam, but I still need you to pay attention. Okay? Because remember what I told you about those.
Sorry, Dr. Marcos, you mean the school exam or like?
No, in your pulmonary finals, there are some questions from here. Yeah, yes, not just, there's some, not a whole lot, but there are some. Okay? I remember I told you that there are some things that throughout our classes we put in there that are very unique knowledge that only you will have as a true graduate. For EKG, is ROE. And I want you to practice that. I want you to interpret EKG with ROEs in your mind. Just start axis, rate, reading, orientation, and move on like that. This is where I'm going to give you the second piece. I'll let you know when I get there. So, you're going to put your patient on mechanical ventilation. What does that really mean? Let's talk about normal ventilation. So respiration, you're breathing, all of you are breathing and you're eating and you're talking. Yeah, but really, what is the work of respiration? The work of respiration is the change in pressure and the change in volume. In order for you to get air into your lungs, you have to create a negative pressure, increase the thoracic volume, and air will rush into your lungs. So the work, if you talk about the work of respiration, is the change in pressure times change in volume, right? So the work of respiration is the product of the change in pressure needed to inflate the lungs and change the lung volume. Now, if the airway resistance to airflow increases or the compliance decreases, then the work of respiration becomes more difficult. So if I stand on your chest and tell you to take a deep breath, can you take a deep breath? Because there is a lot more pressure you need to generate to breathe, right? So whenever there is change in pressure or volume, or there is even obstruction, like airway resistance, if the resistance to flow is increased, again the work of respiration is going to increase. Say for instance, if I have you breathe through a straw and run up and down the stairs, and you have to breathe only through the straw, you will sweat, right? Because the resistance you're going to encounter to get air through a straw is not going to be the same thing as when you're breathing through your nose, right? So the work of respiration is generally the product of changing pressure and changing volume, okay? So I want you to understand the concept of the work of respiration. So respiration is work. Breathing is work. You will not lose weight by breathing, but it's work. Okay? So when you want to put the patient on ventilation, you have to decide which part of the work of respiration are you going to help them with. Are you going to help them with the pressure side of things, or are you going to help them with the volume side of things? So in other words, am I going to control the volume and let the pressure play out? Or am I going to set the pressure and let the volume play out? Let me tell you exactly what I mean by this. So, you have to decide for the mechanical ventilation, are you going to do volume control or pressure control? When you do volume control, you set the machine to deliver a specific volume of air, right? Regardless what the pressure is. The vent is set to deliver specific volume of air, right? That is volume control. That is, you set the volume of air the patient is going to get. Okay, that was called volume control. Now, there are times you'll be like, well, I don't want to control the amount of air the patient gets, but I want the machine to stop pushing air into the patient whenever this pressure is reached. So you set the pressure. When you set the pressure and you let the volume of air play out, you say your patient is going to be on pressure control ventilation. When do we make pressure control versus volume control? Let me ask you, when do you think it makes sense? So Stanley, if you have somebody with asthma, the airway is obstructed, the guy comes to you, he's in florid respiratory failure, stuck in inspiration, and you think you're going to need to intubate this guy and put him on a vent, would you rather do volume control or pressure control? And why? Just think for a minute.
Okay, so let me process this, right? So
the guy is asthmatic.
Yeah.
He's in severe asthma. He's stuck in inspiration. You want to put him on a vent.
Yeah.
Would you do volume or pressure control?
Because like he's basically not getting enough air, so I'd assume volume. But if it was like a restrictive situation, I'd like wait till the pressure reaches what the pressure needs, and then like stop it there.
Exactly. So you see, in an asthmatic patient, there is hyperinflation of the lungs, right? If you force air into that lungs, you're going to cause barrel problem. You'll pop that lung, right? Because there is obstruction and there is gas trapping already. So the lungs are already hyperinflated. So you will not do volume control. Because it's an obstructive situation with air trapping and hyperinflated lungs already. So you will do a ventilation, but you will do pressure control. In other words, you will set the vent to deliver just enough air to maintain a particular pressure, so you don't pop the lung. You got that? But supposing you find a patient with massive pulmonary edema, and the lung compliance is so reduced, the lung is so now elastic. Christian, what kind of vent setting would you use? Would you use pressure control or volume control?
It's super.
It's stiff. The lung is so stiff. Thank you. You will set the machine to deliver enough air, and you monitor the pressure, right? So that is how you make the decision. Whether you're going to use volume control or pressure control depends on your patient and what you're trying to achieve. Okay? So when you do volume control, volume and flow are preset, airway pressure changes are monitored, right? And how do you monitor the pressure? You set a high limit and a low limit. So basically, you set the vent to say, I want you to deliver this volume of air regardless. That increase in volume will be associated with increasing pressure. I'm expecting that, but I like to be notified if the pressure goes above this limit or if it falls below this limit. So in volume control, you set the volume amount and then you set high pressure and low pressure allowance levels. Okay? You got that? Whereas in pressure control, you say deliver enough pressure, enough volume, but do not allow the airway pressure to go above this limit, right? And then you now set volume allowance. If any reason you're not able to deliver this much air, I need to realize. So the allowance system will come up if for any reason the machine couldn't deliver a breath because of high airway pressures. So the most basic thing about ventilation is that you want to put the patient on mechanical ventilation. You're going to take over the work of breathing for that patient. And then you have to decide, am I going to take over the ventilation on the volume side, or am I going to take over the ventilation on the pressure side? So the first basic question you have to ask yourself is, am I going to use the volume control or the pressure control ventilation? Generally speaking, we start with volume control. Everybody goes to volume control. The only time you do pressure control is when your patient on volume control is not doing well, and you are maxing out on peak, and I will explain that in a minute. But generally speaking, everybody starts with volume control ventilation. All right? So let's move on. Yes?
You have a patient on the vent and you have to wean them off when you're, okay, I just want to make sure. So your volume, you just kind of give them less and less and see how they do with it?
No, I'm coming
Oh,
there.
okay.
It's more technical than that, right? So you've now decided that your patient is going to do an event. You get the event, they used to look like this, but not like this anymore because they're now so small and compact, right? And they lot more storage space now. Before you can put the patient on a vent, you have to connect the patient to the vent. And the way you connect the patient to the vent is through what is called endotracheal intubation. So you have to have a tube that goes into the trachea. And that tube is now connected to the vent, okay, to vent lines. Endotracheal intubation can be through nasotrachea. Now you put the tube through the nose and it goes into the trachea, or it could be orotrachea. You put the tube in the mouth to get it into the trachea. Either way, it is anesthesiologists that do it because they are used to that for every surgery they do, right? Okay, it's nice, a cool thing if you learn to do it. But if you must learn to do it, make sure you do it well. Because if you don't do it well, somebody is having respiratory distress, you're going to put a tube in their stomach, in their esophagus, thinking you have it in their trachea, and you're going to be pumping air into their gut. That's what it is. Okay? So, you can get a tube down through the nose or through the mouth. Orotrachea is easier because in emergency situation it's a lot easier. But the standard way to do it is nasotrachea. And how do you know that your tube is in the trachea? You listen to the lungs. So once you put the tube in, you listen to the lungs. And sometimes you may not be able to hear the lungs very well because of the nature of the patient or their disease. You can connect the tube and put a capnometer on top of it. A capnometer measures the carbon dioxide level. So when you're in the lungs, carbon dioxide level will be higher. But if you're in the gut, carbon dioxide level will be low. So you can use a capnometer to determine where you are, whether you're in the trachea or you're in the esophagus. Right? You're with me? Good. Now, the ultimate gold standard for you to know where you are is chest x-ray. You want to do a chest x-ray and see the trachea, the endotrachea to where it's supposed to be. Endotrachea, within the trachea. Okay? That's what the tube is. Pay attention to this. The endotracheal tube is a tube, but it carries a cuff. Do you see that cuff? See that cuff? Once the tube is in the trachea, the cuff is inflated with this tube right here. So you put a syringe and you push air, and that air goes and inflates this cuff. And once this cuff is inflated, this cuff now gets inflated. That is how you know that the distal cuff is inflated. You got that? So you push air. So what happens? Once you put this cuff on, that tube is now one same continuous chamber with your patient's trachea. Basically, that tube becomes an extension of the patient's trachea because it is now one continuous chamber. The tube is inside the trachea, the balloon cuts off the air, the spaces around the tube, so that the airway is now continuous with the tube. You got it? Mm-hmm. That is so important. And now you get the vent lines. You disconnect this mask and put this on top of their inspiration, expiration. That is how you connect your patient to the ventilator through the endotracheal tube. You have a question?
Are they sedated? Are they sedated during this?
Most of the time, before patients are going on this, they are already like passing out themselves of their disease.
Okay.
But generally, we don't sedate them to
do that.
Them. They tell you, we need to put you on a bed right now. Yeah, okay. There you go. But most people sedate the patient, right?
Okay.
But this is a mess. Okay? It's a hot mess. All right. By the time you're here, your patient is like on their way out. This is critical medicine. This is something you're doing to save this patient's life. So many times they don't even have a choice to even tell you what to do or what not to do. You have to do what you have to do to save their lives. Okay? But everybody understands how the ET tube is now one continuous line with your trachea. That is very important. Okay. So the anesthesiologist will intubate the patient, and then the RT will come to you and say, I need the orders for the vent settings. In order for you to give an order for vent settings, they are looking to you for, tell them the mode, the rate you want, what the tidal volume should be, what do you want the peak flow rate to be, and what FiO2 do you want, and whether you want them to set a positive and expiratory pressure. So you need 1, 2, 3, 4, 5, 6 parameters on a standard vent order. Okay? For the modes, there are so many modes. There is a handout you have. This APRV is a new mode, but you will understand it after we've gone through these other lectures. So let's talk about mode. There is continuous mandatory ventilation called CMV. Continuous mandatory ventilation means that the ventilator senses and supports every breath the patient initiates, regardless of the set ventilation rate. So you put the patient, say, the vent rate is 18. Yeah, the vent rate might be 18, but the ventilator has a sensor. Every time the patient creates a negative pressure in the thorax and attempts to breathe, the ventilator will sense that attempt and will push and deliver the air. Right? That's why it's called continuous mandatory ventilation. Okay? So you might set your rate at 18, but that does not mean the vent is limited by the rate of 18 breaths per minute that you set. Then the question is, why then do we set the rate? We set the rate just in case the patient does not breathe. So if the patient does not initiate any breath, the machine will deliver 18 breaths per minute. But if the patient initiates 30 breaths per minute, the machine will deliver 30 breaths per minute. So the rate on CMV is a backup rate. You got that? Excellent. Now, CMV can both be volume control and pressure control. Volume control, CMV, is what we prefer. That is how you want to initiate mechanical ventilation. And what you generally do is that you set the volume and then you set the pressure, high and low pressures. So airway pressure alarms are set for high and low peak airway pressures, generally plus or minus 10 millimeters of mercury above and below baseline values. So from the time you put the patient on the vent, the pressure, the airway pressure will come to a particular level, a baseline level, right? Depending on what the patient's situation is. If the patient is, say, an asthmatic patient, there will be a high pressure. If the patient is a COPD patient, it might be low pressure. If the patient is ARDS, pressure might be normal. But regardless, you don't know everything going on in that patient. It could be an asthmatic patient that developed pneumonia and went into ARDS. It doesn't have to be one particular condition. So you don't have any preconceived notion of what the pressure is going to be. You put the patient on the vent, you connect them to the vent, you set the volume, the machine delivers the breath, you see where the pressure settles. And then you set your high and low alarms plus or minus 10 above that and below that baseline. You got that?
Yes.
Okay, good. So that is how that is done. Pressure control, CMV, is indicated for severe ARDS where the lung compliance is very poor. In other words, you're going to set the machine to deliver a breath, but the lungs are so stiff that you're not going to set volume. You're just going to say, deliver as much breath as you can deliver to keep the airway at this level. Right? So that is when it is pressure control. This one, believe me, I never used pressure control ventilation before. This is what we use when patients are really dying. Surgeons use it a lot. Okay? And many times, pressure control ventilation is often combined with what is called reverse IE ratio. You will understand that a little bit. IE ratio is inspiration, expiration. Right? Under normal circumstances, you spend more time in expiration than inspiration. So your IE ratio is usually like 1 to 3 to 4. 1 to 3 to 1 to 4. You spend about a third of the time in expiration than in inspiration. But when you are using pressure control ventilation, you set it to be reversed. You give the patient less time in expiration. And the reason you do that is you want to keep the lungs partially inflated so that subsequent breaths are easier to deliver. Okay? This will become clear to you in a few minutes. Just know that what you want to do for mode is you want to do CMV. Okay? And you should know what CMV means. CMV means it's a continuous mandatory ventilation. The patient will get a set breath if they don't breathe. But the machine will deliver breath every time the patient initiates it because the machine has a sensor that senses the patient's attempt to breathe. Okay? And the machine can sense it because the ET tube makes the patient and the machine continuous. You got that? All right. Okay, no. So now the question is, what is the rate you will set? Generally, we set the rate at 10 to 15 breaths per minute. Right? So you set the machine to deliver breath at 10 to 15 breaths per minute. But don't do that if that's what standard is. If your patient was breathing at 30 per minute before you intubated them, don't put them at 10 to 15. You put them at about 20 to 25. So you put the patient on a rate that is 5%, 5 breaths less than their baseline. So if your patient was breathing at 25 per minute before you intubated them. When you intubate them, their breath must be about 20, 25. Okay? But if the patient was breathing normally and you're intubating just to protect the airway, then you do the standard 10 to 15 because that's what normal is. Okay? Good. So your rate is 10 to 15 or respiratory rate minus 5. So what tidal volume would you set? Because remember, you're going to deliver air into the patient. You want to deliver the normal volume that the patient ordinarily would take in and out on their own. How do you figure that out? That's the tidal volume. Generally, we use 10 mils per kg. Kg, ideal body weight. Remember, I keep telling you, you don't gain weight in your lungs. Your thoracic cavity does not increase because you gain weight. Your lung volume don't increase because you gain weight. So when you're calculating tidal volume, you use ideal body weight. So you set it at 10 mils per kg. So if somebody's ideal body weight is 70 kg, you will set the machine to deliver 700 mils of air. Right? That's the tidal volume. Okay? So you set the tidal volume. But if your patient is COPD or ARDS, you don't use 10. You can appreciate why you will not use 10. Because in COPD, the lungs are hyperinflated, right? If you deliver the full tidal volume, you might pop the lung, right? So when there is issue of COPD or ARDS, you will use 6 mils per kg. You understand how that can protect the lungs, right? Right?
Yes.
Good, thank you. And now, the question is, you've set the rate, you've set the mode, you've set the tidal volume. Now the question is, how quickly do you want the vent to deliver the breath? Right? How quickly do you want the machine to deliver the breath? That is what is called the peak flow rate. And generally speaking, peak flow rate is 4 times minute ventilation. Okay, so if you set a rate of 10, a tidal volume of 700, what is minute ventilation? 7 liters, right? Right? What is peak flow rate? 28 liters. You got it?
Can you explain to me? Sorry.
Okay, minute ventilation is tidal volume times respiratory rate. Is the amount of breath per minute, right? Is the equivalent of cardiac output, right? So we said you set the rate depending on who you're dealing with. A normal person that you're just intubating to protect the airway, you will use 10 to 15. But if the patient was seriously tachypneic, you will use whatever the baseline rate minus 5, right? So you determine the rate. Tidal volume, you say you use 10 mils per kg, ideal body weight. But if there is COPD or there is ARDS, you will 6 mils per kg. That's tidal volume. Now, minute ventilation, therefore, is tidal volume times the vent rate, right? So if you use 10 as rate, and then you say 10 mils per kg and in a 70 kg man, so the tidal volume will be 700, right? Well, 700 times 10 is 7 liters, right? 7 liters, that would be the minute ventilation, right? That 7 liters, the minute ventilation times 4 is what your peak flow should be. The peak flow rate is how quickly you want the machine to deliver the breath. Why is that important? Why is that important? The higher the peak flow, the quicker the breath is delivered. Right? So think about it. If respiratory time is start, stop, and let's assume hypothetically that this is inspiration and this is expiration. Let's assume that in a single respiratory cycle, I spent half the time to inspire, and I spent half the time to expire, right? Now I have my patient connected to the machine. If I give the patient a normal peak flow, the patient will spend about half in inspiration, half in expiration, right? But if I give them a higher flow rate, I will reduce the amount of time, I will shift it towards inspiration. Inspiration will take place over a shorter period of time, and there will be a lot more time for expiration. Right? The only way I can manipulate how much time the patient spends in inspiration versus expiration is by manipulating the flow rate. So why would I want to manipulate the flow rate? Remember, in asthma, the problem is never inspiration. In asthma, the problem is expiration. Because expiration is the one that you can't control. The lungs are on their own with the size of the diameter of the airway. So when somebody has asthma, they are usually ventilated with high flow rate. The reason is because you want that breath to take place within the first 25% of the respiratory time. So the patient can use the remaining 75% to get rid of that breath in expiration. Are you with me? Right? So, flow rate manipulation is extremely important. That is why for COPD and asthma, we often add 40% to whatever the minute ventilation is, to make sure that we keep the breath as quickly as possible to limit inspiration so the patient can have a lot of time to exhale. Okay? So, we use high flow rate to increase IE ratio, inspiration, expiration ratio. You want to increase it from 1 to 2 to about 1 to 4. Are you with me?
Yes.
Anybody confused? If you're confused, you have a right to be confused. This is complicated. I want you to tell me. I want you to be clear now, because you really have to be clear now. If you're not clear now, you will not understand anything about that article, and that article is important. All right, so you now know what IE ratio is, right? How do you manipulate IE ratio? By manipulating the flow rate, right? What is flow rate? Is how quickly do you want the machine to deliver that breath to that patient? Okay? So the RT, you generally don't give them peak flow rate. They will compute the peak flow rate. All you need to give them is give them the rate you want, give them the tidal volume you want, and you're done. They will compute what the flow rate should be for that particular patient, right? But if you are really interested in making sure your patients get the right benefit and little harm from that mechanical ventilation, you want to go back and look at the peak flow rate that IT is using, that RT is using, the respiratory therapist. They're the ones that push the vent around in the hospital and take care of vent patients. If your patient has COPD, you want to make sure that they use 40% more above the baseline. Whenever you put anybody on a vent, FiO2 is 100%, period. You begin with FiO2 of 100%. Okay? So a standard vent order in a 70 kg man that was intubated for upper GI bleed will be rate of 10, tidal volume of 700 mils, peak flow of 28 liters per minute, FiO2 100%. Y'all got that, right? What if the patient is a lean 60-year-old asthmatic patient? They are now intubating 26-year-old 60 kg asthmatic patient. So, Kara, what would be the vent order?
So then you would have to do.
And the patient was tachypneic at 20 when he came in. No, 25 when he came in.
So we would use the 6 ml per kg.
So we use 6 ml per kg, and since he is 60 kg, so he's 360.
360 times all of, and then you multiply that by 4, right?
No, minute ventilation. Tidal volume is 360.
Okay.
What was it?
Then what about the rate? What rate would you use?
Well, the tidal volume is 360, so I did 360 times his respiratory rate, which you said was 20.
I said he came in, before he was intubated, he was breathing at 25
So then
per minute.
360 times 25.
Minus 5. You have to
Minus.
25 minus 5.
Oh, minus 5.
Right?
So 360 times
Okay.
20.
Why do you want minus 5? Because the machine is a machine. It's going to be more efficient than the patient. So if the patient was doing 25 on their own,
Yeah.
the machine can do the same, achieve the same result at 20. So you lower it. So the rate for that patient will be 20. His tidal volume will be 360. And then you multiply the rate and the tidal volume, and then you get minute ventilation, which is now it's 20 times 360, which is about what? 3,600 plus so 7,200, right?
And then I
7,200.
have to take 40% of that, right?
They add, first of all, you
Add
multiply
40.
that by
Yeah.
4, and then add 40% to it.
Yeah.
Exactly. You understand? Do you all follow that? So that's the way you compute the event order, right? First of all, you ask yourself, what is the rate I'm going to use? If the patient is a normal patient, no problem, you use 10 to 15. If your patient was tachypneic and in respiratory failure, you look at their baseline. What were they doing before we intubated them? They were doing 35, you go back 30. Let me tell you something. Generally speaking, regardless what the weight of the patient is, you never put anybody on the vent with a tidal volume less than 500. The lowest you go with tidal volume is 500. So let's recompute there. So this patient that is 60 kg, asthmatic, came in breathing 25 per minute. So his tidal volume now will be 500, right? His rate will be 20. So his minute ventilation will be 500 times 20, which is 2 liters per minute. His flow rate will be 4 times that, which is 8. You will add 40% to that, which will be 12. By the time you put a flow rate of 12 liters per minute on that patient, the IE ratio will be about 1 to 4. Why would they feel better? Because now you're going to rush the breath in and give them a lot more time to exhale. Okay? That is why it works. You manipulate IE ratio in patient with obstruction to allow them more time in expiration so they don't stack breath. Because remember, in asthma, the problem is that the patient takes a breath, and because expiration is passive and there is obstruction, they are not able to get rid of the air they took in before they took the next breath. So they stack breath. It is that stacking of breath that gives them that hyperinflation and ultimately results into their lungs popping. So when you put them on a vent and you put them on a big flow rate that allows them to spend more time in expiration, they will feel decongested because they have more time to exhale before they breathe on the machine. You got that? Is there anyone that is fuzzy about any of this? Because you know why this is important for you? You're going to be a clinician. And sometimes people don't understand what physician assistants are. An RT will look at you and question your order. You have to be confident and that's what it should be. I need to change this to this. And you can't be wavering. No, you need to understand this clearly. Is there any confusion anyway? We're good, right? Excellent. So let's go. Now, the RT will ask you, oh, by the way, I told you the standard is FiO2 of 100, right? Would you give 100% to somebody with COPD? No. Thank you. Because they have hypoxic drive. If you give too much oxygen, they stop breathing. So, standard is 100% FiO2, but in a COPD patient, it's 50%. Right? Good. Now the RT will ask you, do you want me to give PEEP? PEEP is positive end expiratory pressure. What the heck is that? Under normal circumstances, the alveoli collapse at the end of expiration and they open in the subsequent inspiration. When you use PEEP, what you do is you force the patient to keep the alveoli open partially at the end of expiration. So you don't allow the alveoli to collapse completely with expiration. You keep it partially open. That's why it's called positive end expiratory pressure. So you use positive pressure to keep the alveoli partially open. Why do you want to do that? Because a partially open alveoli is easier to inflate on the subsequent breath than a completely collapsed alveoli. You got that? Mm-hmm. So we use PEEP, positive end expiratory pressure, to keep the alveoli partially open so that the subsequent breath, that alveoli can be distended with less pressure. It's like a rubber band, right? The force you need to initiate the stretch of the rubber band is a lot less than the force you need to keep it stretching. You understand what I'm saying? You get a thick rubber band. To start pulling it, you need a lot more force. But once you begin to pull, you need less force to keep pulling it. Right? So the same thing, we use PEEP to keep the alveoli partially open at the end of expiration. Under normal circumstances, at the end of expiration, the alveoli should be collapsing, right? But we would deliberately use a positive pressure to keep it partially open so that the subsequent breath can be easier on the patient. And generally speaking, when patients are on vent, everybody gets a PEEP of 5. And PEEP is measured in centimeters of water. That is the unit of pressure that we use. Okay, so this is a standard vent order. You have decided what mode. Everybody goes on volume control. Okay? If volume control does not work, then you do pressure control. Usually when the peak airway pressures are high and you're afraid the patient is going to pop their lungs. Okay? So that is your vent order. So now the RT took your vent order and they initiate it. Now, everybody understands what I mean by PEEP, right? I want to just take a few minutes to talk more about PEEP. Even though we as clinicians, we can introduce PEEP into a patient, sometimes PEEP can develop as part of the patient's disease. Let me give you a good example. If an asthmatic patient is having a severe asthmatic attack, and they keep trapping air, what will happen to the thoracic pressure? It becomes positive, right? Right?
Yeah.
If you trap enough air, you develop positive pressure in the chest. And that's when they can go into hypotension because venous return will be impaired, right? Well, that is auto-PEEP. Right? When a patient's disease process predisposes them to developing positive pressure in the thorax at the end of expiration, that is a PEEP. The PEEP that the patient developed themselves is what we call intrinsic PEEP or auto-PEEP. Okay? It's a positive end expiratory pressure that you would develop with progressive stacking of breath as a result of inadequate exhalation before inhalation. So if the patient keeps taking in tighter volume and they're not able to get rid of the air because of obstruction, they keep getting this positive pressure in their chest. And that develops to PEEP. So that is called an intrinsic PEEP. How else can it happen? How else can you get auto-PEEP on the vent? Let me ask you something. If you mismanage a patient's flow rate, right? Say you have a patient, you overcalculated their tidal volume, or you put them on a rate that is higher than it should be. You give them a lot more breath in inspiration than they can get rid of, right? You push them into auto-PEEP. because you're going to give them more air than they can exhale. Remember that exhalation is passive. Inhalation, you can actively take in breath. But to get rid of breath, your lungs recoil and your airway diameter are the only forces you have. Even on vent, you can push the air down the patient's airway, but you cannot use the vent to suck the air out. That doesn't happen. Expiration still has to occur under the elastic recoil of the lungs and the diameter of the airway. Are you with me? Mm-hmm. Good. Right, so you get orthopedic if you miscalculate your patient's minute ventilation. Either you give them a too much tidal volume or too much ventilation rate. Another way you can increase orthopedic is you miscalculate the flow rate. In other words, your flow rate is so slow that your patient spends more time in inspiration and there is little time for expiration. So the breath gets stacked. Right? How else can that happen? Airway obstruction, like in asthma. You don't want orthopedic. You know why you don't want orthopedic? It's a positive pressure in the airway. It can pop the lung. Your patient will develop pneumothorax. Okay? Now, extrinsic PEEP is the one that we introduce to make the breathing easier for the patient. Okay? So I want you to know that PEEP can be extrinsic or intrinsic. So that's my digression, my 3-minute digression talking about PEEP. Okay? Everybody good?
Yes.
Good. You understand clearly how you can introduce PEEP by miscalculating minute ventilation and flow rate. Good. That's why you have to be very clear on tidal volume. It's 10 mils per kg ideal body weight. The commonest mistake is when a clinician calculates tidal volume based on the patient's body weight instead of ideal body weight. So somebody weighs 150 kg. You can put them on tidal volume of 1,500? Seriously? No, that patient the lung will pop within 1 hour on that vent. Because that tidal volume is too high. Tidal volume is supposed to be calculated on ideal body weight. Okay? So now, that is PEEP. Moving on. So, your patient is now on the vent, and everything is fine. The patient is breathing. Let's look a little bit closer. What is it that determines movement of air on a patient when they're on the vent? It's pressure that drives air. Right? When your patient is on the vent, the airway pressure and the lung compliance determine the amount of pressure that you would need to move air through that lung. So air moves through passive respiratory system according to this equation. So there is airway pressure that is known as trans-respiratory pressure, which is the pressure difference between the inside and the outside of the patient, right? And then there is elastance. In other words, how compliant is the lung? Are the lung easy to expand and recoil? Is it doing it? So we talk about elastance or compliance. We talked about that earlier, remember? Okay. And then resistance. Is the airway open or closed? These are the factors that will determine the amount of pressure in the airway. So if you have a patient that has severe asthma, the airway pressure will be high because of airway resistance, right?
Wait, can you repeat that?
These are the factors that determine the amount of pressure in the airway. The resistance, the lung elastance, and the airway pressure, right? If you have somebody with asthma, the airway pressure will be high because of increased resistance. If you have somebody with ARDS, the airway pressure will be high because of reduced compliance or increased elastance of the lung. Remember at the beginning where we talked about elastance is the opposite of compliance? Okay, good. Now, let me now ask you. I'm sure if you've been in the hospital and you've seen people on the vent, there are times you're going and everything is beeping. I love the stories there. Pew, 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 pew. Right? Usually, once your patient is connected to the vent, those vent lines and your patient are 1 minute. They have become really 1 minute. So if the patient coughs, they will create a jerk in the airway pressure and they will trigger an alarm. If you went to greet, if the patient's grandson came with a parent to visit grandma and tripped over the vent and disconnect the vent line, the airway pressure will fall and the alarm will come up. So many times when you are in the hospital, in the ICU, and you're seeing patients, you hear these alarms. They reflect pressure changes. In order for the alarms to reflect pressure changes, that means the patient is on a volume control ventilation. Remember that, right? Because it's only in volume control that you set pressure alarms. In pressure control, you set the pressure and you have volume alarms. Remember? Right?
Yeah.
Okay, good. So, let's talk about airway pressure changes. What are the things that can make the airway pressure go high? So you're going there and your patient is on a vent and you're on call. And you know at call you say the vent is beeping. And you go and you see that, oh my goodness, the vent is beeping because the peak airway pressure is being reached with every breath. What should you look for? These are the things you look for. The ARDS is getting worse. The patient has collapsed one of their lungs, or the patient is developing a pneumonia, or the patient is having pulmonary edema, or the patient is having pleural effusion, or the patient has developed tension pneumothorax, or the endotracheal tube has slid down into one of the bronchi instead of staying inside the trachea. Or there is ascites. Now let's take each of these. I don't want you to memorize a list. I want you to understand what is going on. Right? So come with me. Peak airway pressure is going high. ARDS makes your lung rubbery. It's not soft, so it's difficult. So you understand why the pressure will be high, because the lung is stiff, right? Right?
Yes.
Good. Now, atelectasis. When you computed the tidal volume, the assumption is that the two lungs will take the air. So you computed that this patient, based on their weight, they should be able to take 500 mils of air. They have two lungs and they're fine. But all of a sudden, the patient lost a quarter of that lung. You're now delivering 500 mil of air into a space that is a quarter less. What will happen to the pressure? Thank you. It will go up because you're delivering the same volume into a smaller space. Right?
Yes.
If you're delivering the same volume into a smaller space, you expect increase in pressure. Right?
Yes.
Nice try. So, you see, that's the reason atelectasis will make your airway pressure go up. Why would pneumonia do it? Or pulmonary edema?
Fluid's taking up the space.
Eh?
There's some type of fluid in there.
Thank you! Because it's an alveolar filling disorder. Right? When you computed the 500 cc, you computed it based on the assumption that every alveoli will be free. But now some alveoli are now filled with water and pus. Again, you are delivering the same volume into less space. So the pressure will go up. Are you with me?
Mm-hmm.
Excellent. So now how about, why would pleural effusion do it?
Fluid's compressed the lungs.
Thank you, because pleural effusion will compress the lungs. For the same reason, you are delivering the same volume into a less space. Therefore, the pressure will go up. And why will bronchial intubation do it?
Because you're only delivering to that one lung.
Thank you. You are delivering the air that is meant for both lungs into one lung. So the tube are slid down into a main bronchus instead of straining into the trachea. So you are delivering the air meant for both lungs into one lung. Of course the pressure will go up. So generally speaking, when you're called that the patient's airway pressure is peaking, what you do is you walk over to the bedside and you do a thorough examination. So let me ask you, so they called you in the middle of the night, 2 a.m., so this patient's airway pressure is peaking, it's alarming, and you went there and you look at the veins and the peak airway pressure is really high, and then you listen to the patient lungs, and you could hear breath sounds on this side, but there's no breath sound on the left side. What's going on? No breath sound at all on the left side. And the peak airway pressure is going up. What would you say? Yes, what is causing the peak airway pressure to go up in that case? Okay. Health.
Bronchial.
Thank you. That means the tube has gone into the main bronchus on the right. That's why the breath sound is absent on the left. Right? Okay, what if you went there lost and they say the peak airway pressure is peaking in this patient, and you examine the patient and there was reduced breath sound on the right lower lung field, and you percuss and it's slowly dull, and there is no tactile of you patient couldn't do tactile premises or vocal premises because they're an event. All you have is absent breath sound on the right lower lung and dullness to percussion note. What do you think is going on? Dull percussion note, absent breath sounds, right lower lung field. Pleural effusion. Stony dullness is what gives it away. Stony dullness. In athletics, it will be dull too, but it won't be stony. Right? You see how you do these things? So this is what you will deal with. Believe me, you will deal with it. If you take calls in the ICU, you will deal with this. Right? Okay, so what happens if the patient is on event and now peak airway pressure is high, and Tolu, you went there and there is fine crepitations all through the lungs. Pulmonary edema that the patient didn't have before. Right? So you see how you look for these things, and then what will happen, Stanley? So peak airway pressure is peaking in your patient, and you went there and all you could hear is wild bronchi all over the lungs. What is going on?
Means there's bronchi, so it means would it be attention pneumothorax? Oh,
Bronchi.
Oh, my bad. I wasn't down there yet.
I know.
Yeah.
I wanted to push you. So if there is wild bronchi all over the place, you know bronchi generally means airway obstruction, right? That means your patient is having acute bronchospasm. That happens. When patients are on vents, they are making secretions, and sometimes the secretion will trickle down their airway and trigger bronchospasm. And all they need is breathing treatment. Right? So you just see, and you have all this bronchi, you just order the RT to give a breathing treatment, and you go back to your room and sleep. And the patient will be fine. Other times you go there, the patient is in florid pulmonary edema, and then you step back and say, okay, this patient did not come in here with heart failure. Why is the patient in pulmonary edema? And then you realize that they've been running normal saline at 100 cc an hour throughout the patient's stay in the hospital. The man is 58 years old, he's hypertensive, and he's been getting 3 liters, 100 cc of normal saline since he came in. Of course, in the night he will get into pulmonary edema. All you have to do is say, stop that IV fluid, give 2 shots of Lasix and go back to bed. Patient will be fine. right? So I need you to understand the technicalities of this because it's a very important thing to know. Nobody will test you on it, but I need you to know it because it will make a difference in somebody's life. Okay? So when there is high peak airway pressure, you're looking for increased alveolar pressure or increased airway resistance. Sometimes, you know what happens? A patient on the vent will bite on the tube. Well, when they bite on the tube, it will present like airway obstruction. The peak airway pressure will go up. And all you need to do is examine the patient and you will see them biting down on the tube. Say, Miss Jones, stop biting on your tube. And then you hit reset. And that's all you need to do. You just have to examine the patient. If you don't examine the patient, you're never going to know. And you cannot do it standing at the bedside. No, you have to take the stethoscope, look at the patient from head to toe, listen to the lungs, because see what is going on. If you do a good job, you will always find out why the airway pressure is high. Now, let's go to the low airway pressure. Or sometimes it's obstruction. Patients have been secreting secretions and they've been leaking into the tube and they're getting concretions in the tube. And at the end of the day, the patient is completely obstructed. All you need to do is get RT to suction the patient and the airway will be clean. All right? So let's now talk about low peak airway pressure. So the patient, the nurse calls you in the night and says, look, this patient was intubated last week, but since I've come on my shift, the low peak airway pressure has been coming on. What are the things that will cause that? Endotracheal tube dislodgement. Remember that the reason the cough keeps the endotracheal tube in place is because the endotracheal tube is in the trachea. If the patient has been coughing and the cough is now in the pharynx, that is no longer an airtight position. So the patient will leak air around the ET tube and the airway pressure will fall. And how would you know that? When you go close to the patient, when the machine delivers the breath, the jet of air will hit your face from the mouth of the patient.
Stinky.
Because the air is going in the lung and coming right back, leaking around the peritracheal, around the tracheal tube. We call it peritracheal air leak. So the air is leaking around the endotracheal tube. And the way you know it will hit you in the face if you're closing on the patient. Right? So that will happen. Or somebody, a nurse, RT, cleaner, housekeeping person, has come and disconnected the vent line. Or the ET tube has been in so long that it is no longer firm and tight. It's now leaking air. It's in place, but it's not fully inflated anymore. It has leaked. How would you know that? You look at the outer balloon. Because before the distal balloon deflates, the outer balloon will deflate first. Right? You know that other balloon that you put the air in that comes up second after the inner one is inflated? Yes, that will be deflated.
The little one on the outside, right?
Yes.
Okay.
Yes. Okay? And then, God forbid, bronchopleural fistula. If the patient was intubated for pneumonia and ARDS, and somehow in the midst of that admission, their bronchial airway ruptures into the pleural space in such a way that air now goes straight from the trachea straight to the thorax into the pleural space, they have developed a bronchopleural fistula. Of course, that is easy to find because you'll find your pneumothorax right there and then. The trachea will be shifted. The mediastinum will be shifted in the opposite direction, and you pick that up. What I like to do, honestly, with you guys, is to have like a 2-hour session and just create all kind of crazy scenarios for you to kind of figure out what is going on and what would you do in these kind of cases. You will enjoy it. It's really fun. You know? But maybe when we do the review in the summer, we'll do that.
Sure.
But this is what you want to do. All right? Now let me tell you something Any question? Are you good with this?
Yes.
Excellent. So let's
Oh,
go.
Dr. Martins,
Huh?
are you gonna do the review before we take the pack rat?
Oh, yeah. Oh, yes. Oh, yes.
Boom.
Yeah.
There's only 10 minutes left, you guys want to leave that? Because we have class at 4.
You have class at 4?
Yeah.
That's fine. Is this my last class for pulmonology too? No.
No, you have one more.
I have one more review class. Yeah, I will bounce this over to the review and take your questions at that time. Right? So, I should really stop here and continue. I will continue from here when we meet again. But I'm going to ask you some questions just to clarify what I'm saying here. And I'm going to need folks to come up. So, where's my Dwayne? Okay. Come and write the event order for this 28-year-old female bronchial asthmatic coming in with respiratory distress. I'll give you ideal body weight so you don't have to worry. Ideal body weight is 80 kg. I want the event orders for it. For her. What are the event orders? She came in, our respiratory weight is 28, and she's this big. So what is your event order for this woman? Vent orders. So what mode are you going to start with? Is CMB volume control, right? CMB volume control. What is the rate you will use? So you will use 23 per minute, right? What type of volume would you use? Thank you. And you got that by 80 times 6, right? Good. So that's the total volume. Then what? And you said that's 480, right? So what is your minute ventilation? 23 times 480.
You still use 500 though, right? Yeah, didn't you say we always use 500 minimum?
For minimum. So 500 times 23.
Oh,
You said 500 is the minimum no matter what.
So it's like 11. 500.
so 480 will run to 500.
Mm-hmm.
23 times that is what?
11,500.
Is that, yeah, are you with him?
Yes, 1.5.
I'm only writing here, 11,500. Okay, so this is minute ventilation. But for this patient, would you use 11? This is not right. No.
So you multiply.
What is minute ventilation? 500 times 23. What do you say that is?
11,500.
11,500? Okay. All right, in meals, 11 liters. Okay. So, what is the flow rate?
Times 4.
Exactly, times 4. That would be what? About
46,000.
46,000.
Yeah, that's a lot. Feels like 46 liters.
You know why you keep getting thousands? Because you keep in meals. It should be like, so I will round this up to like 12 liters.
46 liters.
Right?
Mm-hmm.
Exactly. So that is what the flow rate is going to be,
But
right?
take 40% of that actually, since she's,
Then you will add 40% to this,
yeah.
right? 40% will be about this plus about maybe 20, 28,
So-
right?
It'll be 40% of the.
40% of 46.
46.
Oh, okay.
So that would be like 48, 50 thereabout.
40% and 46?
Because
44, so 64.
what is 40% of 46?
18 point something, so 18.4, so it's like
18, so it's like
64.
60,
Yes, 64.
right?
Yeah.
So it will be 60 liters. So for this patient, you want to have the flow rate to be about 50 to 60 liters per minute. Why do you want to do that? That will deliver the breath very quickly and give you an IE ratio of about 1 to 4. Yeah, because this is the minute ventilation, right? And we increase it by 40%. Got it? So you will use a flow rate of about 60 liters. Why would you do that? Because you want the vent to deliver the breath in the shortest time possible to allow the patient enough time to exhale. All right? If you don't do that, the reason you will use this unusually high flow rate is because you want the ventilator to deliver the breath in the shortest time possible in inspiration to allow the patient sufficient time in the expiration. You got it? So this is the kind of calculation you do with vent. So let me ask you, Justin, you have a patient on a vent, the nurse calls you in the night and say the peak airway pressure is falling, and you went there, yes, it's true, the peak airway pressure is falling, and you listen to the lungs, there is reduced breath sound in both lung fields, and when you're listening to the lungs, you feel a jet of air hitting you in the face. What is going on?
Probably a loose, or it's dislodging the tube.
Now, which is it? Is it
Cuff?
the tube is dislodged?
Or it's
the
loose,
cuff
I'm
is
sorry.
leaking?
So
Which
there's
one
air
is it?
leaking from, so the seal is broken.
The seal is broken, so there is pericardial air leak. That's what it is. Why don't you think it's dislodgement? Because generally in dislodgement, the tracheal tube will not be in place.
Yeah.
Okay. So if in an exam, I'll tell you, you examine the patient, the tracheal tube is in place, but there is jet of air hitting you in the face. That means it's the cough that is leaking. If I tell you the cough, the ET tube is out of place, it's more out than in, then you say this is dislodgement. The same thing, the same jet of air will hit you in the face. The only difference between dislodgement and peritracheal air leak is that in peritracheal air leak, the ET tube is in place, whereas in dislodgement, the ET tube is not. And usually that happens when the patient goes in a bout of cough on the vent, and they cough out the tube. And almost immediately, it's a very remarkable sight, because with the cough, the airway pressure goes high. Then the cough stops, and the airway pressure just crashes, because the patient has coughed up the ET tube. Right? Good. All right, so what I want to do.
Why didn't we add the 40%? I thought that was only for COPD patients.
Airway obstruction. Generally, COPD and asthma. Yes. Yeah. Okay. So what I want you to do is, before our next lecture, read that. The reason I gave you this is because when I was in training, we had only CMV, SIMV. We didn't have APRV. There is this new vent setting called APRV. I want you to read this article, and then if you understand it, fine. If you don't, we'll talk about it the next class. It's another vent setting that is common now in practice. It has nothing, it just has to do with the mode. You set it, and the RT knows how to put it on the vent and put the patient on it. Okay, I'm going to stop here and take any burning last minute questions. Thank you for the warning. I needed that.
What?
Thank you for warning me about my time. Are you all good?
Yeah.
All right, see you next week.
Dr. Myers, can I ask you a side question? So, at what point are we just